having Dr. Elizabeth Rogawski McQuade today, and she is an associate professor in the Department of Epidemiology, Rollins School of Public Health. Her training is in infectious disease epidemiology, and her research interests are in pediatric enteric diseases in low-resource settings. Her work focuses on complex interactions between early childhood diarrhea, enteric infections, antibiotic use, and their effects on child health and development. She also studies the impact of enteric vaccines and strategies to optimize antibiotic treatment for diarrhea. Please help me welcome Dr. Rogawski.
Hi, everyone. Thank you so much for that introduction, and thank you for having me. I'm really excited to present quite a lot to you today, so hopefully it won't be too much in too short of a time. But just to start, to orient us to the world of diarrhea, so it remains a huge global public health problem. It's the second or third leading cause of death in kids under 5 years of age. And this graph on the left shows the burden of diarrheal deaths over the past few decades. Thankfully, they've been declining, but you can see that there's still about 500,000 deaths each year in kids under 5, and the burden is very inequitably distributed, so most deaths occur in South Asia and sub-Saharan Africa. Diarrhea is a syndrome, so it's defined by loose stools, but it's caused by many different enteric pathogens, viruses, bacteria, and protozoa. And so here's figure showing, based on the size of the square here, the contribution to diarrheal deaths. So rotavirus is the leading cause in terms of viruses, Shigella in terms of bacteria, and there's many other causes. So in that backdrop, I'm going to actually start the talk with sort of my thesis statement, so sorry to sort of cut to the chase here. But in general, in low-resource settings, antibiotics can be useful for diarrhea, but we really need to find this balance between access and excess. So as I just mentioned, there are many bacteria that cause diarrhea. Antibiotics are effective treatment for many of those, but at the same time, we want to limit antibiotic use to prevent the development of antibiotic resistance. So there's really this balance that needs to be struck here between access and excess. And so what I'll talk about today is really a lot of my work that has focused on understanding sort of the burden and impact of antibiotic use and how we might better target therapy to kids who could benefit. So I'll start with evidence on the burden of antibiotic use and resistance, some opportunities for how antibiotics can benefit children, and then potential interventions. So I'll first introduce you to a large observational cohort study that I've worked on that forms the basis of a lot of the analyses that I'll show you today. So this is the MALI-D study, or the Enteric Disease and Malnutrition Study. It was a large observational birth cohort that was conducted in 8 sites. There are 4 sites in South Asia, 2 in Africa, and 2 in South America. It was 2,000 children total, but was really unprecedented in terms of the frequency and amount of data that was collected. So every 3 days, essentially, field workers went to the homes of enrolled children. They collected information on all incident illnesses, all antibiotic uses, among other things like feeding practices, breastfeeding, etc. Every month, heights and weights were taken, and every month and during diarrhea, stool samples were taken. So we measured enteric infections both during diarrhea episodes as well as in the absence of diarrhea, and we used a large panel of molecular diagnostics, so we have something like 30 pathogens tested monthly for 2 years and during diarrhea. So as I mentioned, the field workers went to the homes every 3 days and asked, 2 days ago did your child get antibiotics? 1 day ago did your child get antibiotics? So we have for every day of the child's life whether they got antibiotics or not. And again, this is in the community, and so we know really for any illness the total burden of antibiotic use. So this is quite an old analysis now, but just a descriptive showing of how common antibiotic use is in these settings. So here on the left is an incidence of antibiotic use over the first 2 years of life here on the x-axis. There were 8 sites. The bulletin of the WHO was very insistent that we name them by the specific site, not the country, but this site is in Pakistan, this site is in Bangladesh, so the South Asian sites tended to have higher antibiotic use compared to the African sites that are closer to the bottom. But really across the board, you see that antibiotic use is very common. In the South Asian sites, kids are getting 10 courses a year or something. This is a cumulative incidence plot showing the same data, that in some sites, more than half of kids are getting antibiotics in their first month of life, and in all the sites, the median time to first antibiotic use is before 12 months of life, so in the first year. So just very, very, very common. And at the same time, these children are asymptomatically infected with lots of bacterial pathogens. So these plots are simple prevalence plots. The two colors are two different diagnostics, but you can sort of ignore those. So again, the x-axis here is from birth to 2 years of age, prevalence plots for all these different pathogens. The 4-letter acronyms are for different types of diarrheagenic E. coli, as well as other pathogens. The point to take away from this figure is that they're very, very common. So for Enteroaggregative E. coli, for example, up here, more than half of the stool samples are positive for this pathogen. Campylobacter, also about a third of the stool samples are positive. These detections are when the children are not actively having diarrhea. So there's just a lot of subclinical carriage of pathogens. Even something like Shigella, which is a really common cause of diarrhea, we see it in non-diarrheal stools quite frequently, maybe up to 20% of the time in the older kids. So we have very, very common antibiotic use and really prevalent asymptomatic infections. And so when you put those things together, we have what we call bystander antibiotic exposure. So the idea is that children can be getting antibiotics for any number of reasons. Maybe they have a respiratory infection, maybe they have a skin infection, but they're carrying pathogens asymptomatically in their gut. And so those antibiotics are exerting selection pressure on the bacteria in the gut, even when they're not the target of treatment. So because we had this sort of very, very high resolution data, both about infections and antibiotic use in MALI-D, we could quantify how often this bystander exposure is happening. So here, these are the sort of 5 most common bacterial enteric pathogens that are carried asymptomatically. So again, Enteroaggregative E. coli, this is Enterotoxigenic E. coli, Enteropathogenic E. coli, and Campylobacter. Those are 5 different bacteria that can cause diarrhea. Overall, they get exposed to antibiotics 7 times a year when they're not the target of treatment. So they're just being carried asymptomatically in the gut. These kids are getting antibiotics for something else 7 times a year. When we focus in on drug classes that are more of interest, things like cephalosporins or fluoroquinolones or macrolides, the incidence is much lower across these pathogens, but still, quite sizable and often problematic. And diarrhea, so treatment of diarrhea, is a major cause of these bystander exposures. So here is another way of looking at these data for each of those 6, pathogens that are bystanders, the incidence of antibiotic exposure, but then colored here in a stacked bar graph by the cause of the antibiotic treatment. So diarrhea and dysentery is diarrhea with blood, accounts for about a quarter of all the bystander exposures. Perhaps not surprisingly, respiratory illnesses are the most common cause of antibiotic use and are responsible for a third or a fifth of these bystander exposures. But diarrhea is a major cause. And this is really despite antibiotic treatment guidelines for diarrhea. So these are the older treatment guidelines from 2005 that state very clearly that antibiotics should not be routinely used for diarrhea. They are helpful only reliably for bloody diarrhea episodes, so again, dysentery, where the mother reports that there's visible blood and stool. And the reason that antibiotics are recommended for that subset is that it's suspected to be shigellosis, so caused by that Shigella bacteria. But otherwise, they should not be given. We very anxiously awaited updated diarrhea treatment guidelines that finally came out like 2 months ago, and drum roll, the guidelines didn't change at all. So the guidelines are still that we do not treat acute watery diarrhea with antibiotics. They do recommend it for diarrhea with blood and stool. So what this means is that the majority of antibiotics for diarrhea are against guidelines. So a very small minority of episodes are bloody, as you might imagine. This is an older cohort from South India where we classified antibiotic courses whether they were appropriate or not, and quite a large proportion in this dark blue color are for non-bloody diarrhea that we're deeming are inappropriate based on guidelines. And especially in the youngest children, it comprises more than a quarter of the antibiotic uses in this age group. So a lot of inappropriate antibiotic treatment. This is problematic because of the risks of antibiotic resistance. So on the WHO priority pathogen list for antibiotic resistance, we see several of the pathogens that cause diarrhea. So Shigella is of medium priority, Campylobacter and Salmonella of high priority, and E. coli of critical priority. And this also made recent news in the United States because of reports of extensively drug-resistant shigellosis. In the U.S., Shigella is really isolated in men who have sex with men as a sexually transmitted disease, but there have been untreatable cases due to XDR Shigella. So antibiotic resistance is definitely of concern for bacterial diarrhea pathogens. It is very hard to make inferences about risk of resistance from just burden of use. I am hesitant to even show this slide because it's an ecological analysis, but PNAS required that we put it in. So with all the caveats of ecological analyses, it is true that the more bystander exposures that you see in different sites, the more antibiotic resistance there is in those sites, with very nice correlations. So of course, it's hard to make inferences about individual use and individual level resistance, but we do see globally that the more use in general, the more resistance there is. I'm happy to talk more about that if there are questions at the end. Okay, so conclusion number one is that indiscriminate antibiotics for diarrhea may be harmful, especially among children in low-resource settings. There's just extremely frequent antibiotic use. When that's coupled with these asymptomatic infections, you get a lot of selection pressure on pathogens that could cause disease. And this use is against treatment guidelines. I didn't talk about sort of individual level negative impacts of antibiotic use, but there are also concerns for impacts on the microbiome, potentially increasing your susceptibility to future infections. So we really don't want to be over-treating kids. But there are also opportunities for benefits of treatment. So everything I've talked about so far, for the most part, has been antibiotic treatment for diarrhea, the syndrome. But really that's vague, right? So there are some subset of episodes that are bacterial and that really might respond to treatment. Unfortunately, in most settings, both in low-resource settings and in the U.S., we don't use point-of-care diagnostics. They're not available, and so it's very difficult when a child presents to care to know, do they have a virus, do they have a bacteria, and are antibiotics indicated or not. So that's why the guidelines are totally syndromic. They're based on blood and stools only. But it does lead to this question, how much of the burden of diarrhea is truly treatable, how much is bacterial, and that might respond. And so this is one of the motivations for better quantifying sort of the burden of pathogen-specific disease. So in collaboration with folks at the University of Virginia, I've been part of a lot of work that has really aimed to do exactly that. So better quantify the incidence of specific enteric pathogens that cause diarrhea. So again, going back to this MALI-D study, again, this is this cohort where we have diarrhea episodes and non-diarrheal stools very carefully characterized for infections. And we were able to estimate the incidence of specific causes of diarrhea. So the innovation of this work was the use of molecular diagnostics, so PCR-based diagnostics. It turns out for the pathogens that we care a lot about, particularly Shigella, the gold standard diagnostics, which is culture, so you growing up the bacteria, is very, very insensitive. So the original culture-based diagnostic is this incidence bar in orange. This is in the first year of life and the second year of life. The incidence that we estimate using PCR is in the blue. So you can see the incidence is many-fold higher using PCR-based diagnostics. This is not just detection of any quantity of Shigella. This is actually detection at a high enough quantity that we think is etiologic. So we think that at this quantity, the Shigella is actually causing the diarrhea. And we determine that based on comparison of detections in diarrhea cases and non-diarrheal controls. But the takeaway here is that in the past 5 years or so, we've really changed the landscape in terms of the causes of diarrhea, that these bacterial causes were likely very underappreciated due to insensitivity of the culture-based diagnostics. So we're seeing a lot more Shigella than was previously recognized. And it turns out that Shigella is, it is the most common cause of bloody diarrhea, but it's actually more often a cause of just simple watery diarrhea. So this is again, incidence plot for different pathogens. The blue bars are the incidence of watery diarrhea, and the orange is incidence of dysentery, so that's diarrhea with blood. Here's Shigella. You can see that the orange bar is higher than any of the other orange bars, so Shigella is the most common cause of bloody diarrhea. The guidelines aren't crazy. If you treat bloody diarrhea, you're probably treating Shigella. But actually, Shigella more often causes watery diarrhea, so the incidence of watery diarrhea is many more times higher than the incidence of bloody diarrhea. So the treatment guidelines that say only treat bloody diarrhea are missing a huge burden of shigellosis. We've shown in several different analyses that Shigella specifically is associated with growth faltering in children. We usually use a measure of height, so the length for age Z-score is essentially how long a child is for their age, as a measure of chronic malnutrition. And we see that children who have Shigella diarrhea have a reduction in their length for age Z-score, so a reduction in their linear growth within the few months following their infection. So that is shown by this point estimate. So this is comparing children with Shigella compared to children without Shigella when they don't get antibiotic treatment. And you see about a 0.06 Z-score decrement in a short 3-month window. What's important is that if those children get treated with antibiotics, that decrement completely goes away. So antibiotic treatment prevents the poor growth associated with Shigella. And I'll talk more about this study later, but it was from the Antibiotics for Child with Diarrhea trial. So, told you a lot about the risk of antibiotic treatment, but at the same time, there are opportunities for benefit. So Shigella burden is much higher than we sort of previously recognized. It often presents as watery diarrhea, and so it's totally missed by the WHO guidelines, despite the fact that the guidelines are trying to target Shigella. Shigella diarrhea is associated with growth faltering. I also didn't show you, but it's associated with mortality and other poor outcomes, and antibiotic treatment has shown to ameliorate that impact. So the scales are tipped the other way. Are we missing opportunities to treat bacterial infections with the right antibiotics? So what can we better do to treat kids with antibiotics? So I'll start this part of the talk with a story that starts with the Mordor study, which many of you may have heard of. Made a big splash in the sort of global health community. So Mordor was a trial of mass drug administration with azithromycin. So children were cluster randomized to receive azithromycin or placebo. And the overall effect was that there was a mortality benefit for children with azithromycin, so about a 12% reduction in mortality if you gave everybody azithromycin. It was a huge trial, and so there's been a lot of efforts to identify, what was the mortality benefit caused by. I think we don't totally know the answer, but there are a few pieces of evidence. One here on the left showing reductions in specific causes of death in the Mordor trial. You can see diarrhea here is among one of several things that was reduced in the azithromycin group. And we did a subset analysis where there was enteric pathogen testing and found that among different causes of diarrhea, there was a significant reduction in Shigella specifically. So again, not conclusive that this reduction in Shigella contributed to the reduction in mortality, but is suggestive that certainly azithromycin reduced Shigella, there was a reduction in diarrhea, and potentially that contributed to the overall reductions in mortality. So following this Mordor study, there was a lot of, I'd say, reawakening of interest in antibiotic treatment. This was it's a little bit older now, but a nice editorial in the New York Times that basically made the point that we don't treat diarrhea with antibiotics very often, but bacterial causes of diarrhea are much more common than we previously realized, and often without blood. So exactly this argument that I've just presented to you. And Anita Zaidi, who is a pediatrician from Pakistan who sort of led the diarrheal disease group at the Gates Foundation, had this nice quote, basically saying it's a matter of equity. If travelers are getting antibiotics when they get diarrhea, why aren't we giving them to children under 2 when they're the ones that are at high risk of mortality? Who are we to withhold antibiotics that could prevent children from dying, for some, ephemeral risk of antibiotic resistance? So this is a very powerful, argument to me. And Anita herself funded this trial following that. So this is the Antibiotics for Children with Diarrhea, or ABCD trial. So this is specifically antibiotics for diarrhea. So because we already treat kids with bloody diarrhea, it was focused on children with watery diarrhea. They also had to be somewhat high risk, so moderately malnourished or dehydrated, but they were randomized to receive azithromycin or placebo. And the study was powered for a mortality endpoint, so it was quite a large trial. These are the primary results. So I will say the trial was stopped for futility, so mortality was much lower than expected. And at an interim analysis, based on the primary outcome of mortality, while there was a almost 30% reduction in risk of mortality, it was very imprecise, and they stopped the trial early. This is despite there being significant reductions in secondary outcomes, like combined outcomes of hospitalization or death. But I would say in general, this trial was viewed as a complete failure. If you read the conclusion of the study, it's like antibiotics don't work, don't do it. Which is disappointing for a lot of reasons, and happy to chat about that. We did an analysis looking at a subgroup analysis, basically. So did antibiotics work in the subset of kids with bacterial diarrhea? And the answer is resounding yes. So here we stratified by children that had diarrhea attributed to a bacteria versus they were not attributed to a bacteria. We looked at several outcomes. So this first row is diarrhea on day 3. So did they persist in having diarrhea? So there was 12% reduction in diarrhea on day 3 if you had bacteria versus an only 2% reduction if you didn't have bacteria. There really weren't enough deaths to look at a death-only outcome, but if looking for a combined hospitalization or death outcome, there was an absolute 3% reduction in death or rehospitalization with azithromycin if you had a bacterial diarrhea episode. This is an absolute 3% reduction, so the number needed to treat is quite small there, actually, and is comparable to the number needed to treat that has been used to justify antibiotics for pneumonia, for example. So we felt like this was actually quite a large effect. If you subset only to the children with Shigella, you see even larger effects on diarrhea at day 3, so absolute 14% reduction in diarrhea at day 3, and a similar 3% reduction in death or rehospitalization. This was actually really hard to get published. People don't like secondary analyses of randomized trials, and I think in general this study is still seen as a negative trial that antibiotics don't work. In those guidelines that I just mentioned that are the updated 2024 guidelines, they talk a lot about this ABCD trial and say it's evidence that antibiotics don't work. So we forge on. My conclusion from sort of this body of work is that we really need targeted treatment of Shigella. So the sort of ABCD study, which treated all watery diarrhea, that wasn't enough. There are still enough viral causes of diarrhea that would wash out that sort of effect. And so what we really need to do is better target kids with Shigella. So the rest of the talk, I'm going to talk about 3 ongoing projects that are related to answering these questions. So I'll start with how can we effectively target treatment to children with Shigella. And this is based on a grant that I have with the Gates Foundation. I'm specifically focused on evaluating stool inflammatory biomarkers to identify what I'm calling treatable diarrhea here, but really Shigella. So the premise here is that bacterial diarrhea, and especially Shigella, is inflammatory. So it causes an inflammatory immune response in the gut, and there are biomarkers of inflammation of this host immune response that can be detected in stool. We think that these biomarkers could improve clinical prediction scores to identify Shigella and treatable diarrhea at the point of care. So while we don't have pathogen-specific diagnostics at the point of care, people are working on them, but even the fastest, coolest ones still require some sort of laboratory capacity and take more than an hour to run, really aren't feasible, whereas inflammatory biomarkers could be assessed using a lateral flow assay, some sort of point-of-care rapid diagnostic test. So we think if these biomarkers are useful in predicting Shigella, they could be adapted to be a true point-of-care assay. And so this is an ancillary study to the Enterics for Global Health study, which I'll describe in a minute. But here we're focusing on 4 different biomarkers. So myeloperoxidase, calprotectin, and lipocalin-2 are markers of neutrophils, and then hemoglobin, which is just a component of blood. So we're measuring all 4 of those in stool to characterize their performance in identifying Shigella. So the Enterics for Global Health study is a hybrid surveillance study. It's being conducted in 7 sites. Our sub-study is being conducted in 6 of those sites, so Pakistan, Bangladesh, Kenya, Malawi, the Gambia, and Peru. It's a hybrid surveillance study, so we are enrolling cases from facilities and then doing some sort of intensive census activities in the community to quantify population denominators to get at incidence. For my sub-study, we're just focused on the diarrhea cases, so children show up to care, they have diarrhea, they produce a stool sample, and we test them for those 4 biomarkers. It's actually not trivial to get stool samples from children with diarrhea, particularly if they show up to care and only stay there for an hour or so. So we ended up only getting stool samples on 62% of the children who were enrolled, but that still ended up with over 5,000 children. So here is the distribution of these biomarkers, stratified by whether the child had Shigella attributable diarrhea or not. So red are children that had Shigella detected at a high quantity, CT of less than 31 by PCR. The blue are those that were not deemed attributable by that cutoff. You can squint a little bit, but the red boxes are always higher than the blue boxes. So the biomarkers are higher among the Shigella cases compared to those that have other causes of diarrhea. Maybe the most striking is for hemoglobin. You see quite a much higher concentration of hemoglobin in children with Shigella compared to those that don't. It's not particularly surprising, right? So hemoglobin is a component of blood. We know that Shigella is the primary cause of dysentery, and so you'd expect there to be more blood in the stool of children with Shigella. So we then incorporated all 4 biomarkers plus a slew of clinical and epidemiologic characteristics like their other clinical symptoms, their malnutrition status, their age, et cetera. Used super learning to come up with the best predictive algorithm for Shigella. So these are those results. So I know the text is small, I'm sorry. These are ROC curves. So here on the x-axis is 1 minus specificity. The y-axis is sensitivity. The perfect diagnostics would be like this. So you'd have perfect sensitivity and specificity. The worst diagnostic is a diagonal line, and anything in between is in between. So you want these lines to be closer to the top left corner. The one on the left here is the prediction algorithm that includes the 4 biomarkers. The one on the right is the prediction algorithm without the 4 biomarkers. And there are many lines here because we did cross-validation by site. So we wanted to evaluate the generalization performance of the algorithm. So we learned the prediction rule in 5 sites and held out 1 site and validated it in the held out site. And so for each of the held out validation sites, we get a slightly different RC curve. So you can see that the curve is more towards the top left with the biomarkers than without the biomarkers. It's not great. So the AUC here is 0.73 compared to an AUC of 0.64, with a sensitivity of 70% and a specificity of 66%. So not an ideal diagnostic. You want 90% sensitivity and specificity, something like that. So it doesn't quite get close to that. If we look at sort of variable importance from the machine learning algorithms, age is by far the most important. Shigella very linearly increases with age. But hemoglobin is like the number 2 most predictive thing. And other than that, the season of the year, Shigella can be quite seasonal, so season is very predictive. And after that is the other biomarkers. So while they're not incredibly predictive, they are among the most predictive things in terms of identifying Shigella. If you wanted to deploy this in a low-resource setting, you might not want to have an app with a complicated machine learning algorithm on it. You might just want to make a simple score based on age and hemoglobin. So, for example, you could have 3 categories of age and dichotomous hemoglobin and come up with a score. Billy used some sort of package to make the score. I actually don't know can't say much about it, but it gives you a best score threshold of greater than 6. And what it sort of boils down to is you would treat everybody if they're over 12 months of age and they have a high hemoglobin level, and you would never treat someone under 12 months of age. Relatively simple score would be fairly easy to implement if you had a nice lateral flow assay that could detect, the kids in the upper level of hemoglobin. Yeah.
The outcome for these diagnostics is any Shigella present?
This high quantity that we're deeming attributable. And we've done this with culture as well. It performs similarly with culture. So what's the conclusion here? I would say that hemoglobin is reasonably useful. And it might not reach that 90% sensitivity specificity bar that you might want for a diagnostic, but it does a lot better than what we currently have. So the treatment guidelines are horribly insensitive. It says only treat dysentery. Our sensitivity is like 70%, so much better. And in terms of specificity, it's much better than the current practice, which is to wildly overtreat everything. This is, I think, an improvement. It's also nice because if we really focus on just using hemoglobin, it aligns quite closely with the current guidelines. So the guidelines are to treat dysentery or bloody diarrhea. And here we're offering a more sensitive marker of dysentery, basically. Can we identify occult blood in the stool? The other really cool thing is that there are already point-of-care tests for hemoglobin. So these fecal immunochemical tests are used for colon cancer screenings. The current stage of this research is we're trying a bunch of these FIT tests to see if they have the right sensitivity for, our cutoff, essentially. It's a little bit confounding. The limit of detection seems to be much too high, which doesn't make sense because a lot of our children have visible blood in stool, and you'd think that this sort of FIT test would detect visible blood in stool. But we're still sort of figuring that out with the companies and testing that at our field site in Tanzania. I would just say that yes, I think a rapid lateral flow assay is much more feasible than sort of other diagnostic options. But at the same time, it would still cost money. It would require implementing in low resource settings in a variety of clinical settings, and so there would still be a lot of challenges to implementing something like this. So that leads me to the second ongoing project I'll talk about, which is asking, do we even need diagnostics at all to identify children who benefit from antibiotics? So this is an analysis where we're trying to identify optimal treatment rules for antibiotics for diarrhea. And the rationale here is that, this whole talk is predicated on, we assume that bacterial etiology is the main determinant of whether a child should be treated or not. It's the main determinant of whether the antibiotic helps them. But that may not be the whole story. So it may be that age and malnutrition and other factors that are sort of unrelated to the pathogen causing the diarrhea are also important determinants of treatment benefit. It would be really cool if those factors were sufficient in identifying who benefits from treatment, because then we wouldn't need the diagnostics at all. Of course, we don't have point-of-care diagnostics, and so if we could predict who benefits just based on sort of readily observable clinical characteristics, that would be really nice. So we applied, very fancy, doubly robust, machine learning, all the things, to estimate these optimal treatment rules. And I think the results are fairly, I think, quite interesting. So what this pipeline does is that essentially the goal is to identify a child level or estimate a child level effect of antibiotics. So can we say for an individual child, conditional on all their covariates, what we expect their, essentially their risk difference for an outcome, in this case diarrhea on day 3, would be if they got antibiotics versus if they didn't. So that's what all these dots are here. So this is at an individual level what we expect their risk difference to be. And so we use machine learning to estimate these things, and we can see sort of what factors are associated with treatment benefit. So here we're focused on the diarrhea at day 3 outcome, and I'll just mention this analysis is in that same ABCD, or the antibiotics for children with diarrhea trial. So as you might expect, here we have Shigella quantity increasing. You see that the risk difference gets more negative. So that means that the treatment effect is larger. So among children who get azithromycin, they have a larger reduction in risk of diarrhea on day 3 when there's more Shigella there. So this is kind of what we expect. The more likely you are to have Shigella diarrhea based on your Shigella quantity, the bigger the benefit of antibiotics are. And you sort of see a nice reverse association with rotavirus. So as you increase rotavirus quantity, which we don't think is treatable, you see a reduction in the benefit. So based on these individually predicted treatment benefits, we can threshold them and say, okay, I'm going to create a treatment rule wherein I treat everybody who has a larger than, let's say, 7% risk difference. So that's all the dots here in orange. We say they have an individual benefit that's greater than some threshold, and so we treat them. You can see that we treat most of the people that have high Shigella quantities and those that have low rotavirus quantities. Interestingly, if we look at a different outcome, specifically a more severe outcome, so hospitalization or death, you see that these associations are a bit less clear. There's not such clear linear relationships between pathogen quantities and treatment benefit. And in fact, we see that the association is actually stronger related to a measure of malnutrition. So the weight for length Z-score is a measure of how wasted a child is. So we see that the treatment benefit is bigger, so the risk difference is more negative in children who have a lower weight for length Z-score, so children who are more malnourished. And you see a similar but sort of less striking association with length for HG score. So for this sort of long-term severe outcome, we see that the child characteristics or the malnutrition status is actually maybe more important than the pathogen that's there. So hold that thought. So based on these individual level treatment effects, we can threshold them to say we treat this group that has a treatment benefit greater than some value, and we can estimate the overall treatment effects in those who are recommended treatment by our rule compared to those who are not recommended treatment by our rule. So for the diarrhea at day 3 outcome, we treat about a third of children, so 28% of children. In those that are recommended treatment, we expect a risk difference of about a 10% reduction in risk. Among those who we don't recommend treatment, we expect only a 4% reduction in risk. So saying we could target treatment to this group that has a larger benefit. We can do something similar for rehospitalization or death. The absolute effects are smaller. It's a more rare outcome, but it's a similar story. These rules are based on sort of all the available data, so clinical, host information, and the pathogen diagnostics. But I want to be able to do this without the diagnostics. So we can create rules using different types of variables. So here, this is the rule where we use all the variable information, but we can create other rules that are just available, that just use pathogen diagnostic data here, or that just use the host clinical characteristics here. For this day 90 rehospitalization or death outcome, notably the effects are imprecise and overlapping, but the point here is that we can get a decently good separation between effects in those who are recommended treatment and those who are not, just based on the host characteristics alone. So the pathogen quantities are useful, but the host characteristics are also sort of equally useful. And if we look at the correlation between the predicted individual level benefits using our sort of comprehensive rule that's based on all the information, with that based on just the host information, you get quite good correlation, and actually better correlation than if you compare it to the pathogen quantities, so the diagnostic-only rule. So our conclusion from this is that you actually can predict heterogeneity quite well just with the host characteristics, and really slightly even better than if you use the diagnostic information. Again, this is for the hospitalization or death outcome. We don't see the same thing for the day 3 diarrhea outcome. So for a very proximal diarrhea duration outcome, it's really all about the pathogens. But for these longer-term outcomes, as you might imagine, mortality is going to be really affected by whether the child is malnourished. And so we're suggesting here that you could essentially predict 2 benefits just with those host characteristics. Okay, so the conclusion for this project is yes, pathogen etiology is a really strong determinant of these proximal diarrhea outcomes like diarrhea duration, but our host characteristics are equally informative if we're interested in severe outcomes. And so, you could theoretically target treatment in the absence of diagnostics by using a treatment rule like the one we just showed based on clinical and host characteristics. Okay, I don't have a ton of time, so I'll just make the last point, which is this last ongoing project that answers the question, if we know that antibiotics are effective and we really should be treating bacterial diarrhea episodes, are there other ways that we can reduce antibiotic use? So enter vaccines. So vaccines have recently, there's been a lot more interest in vaccines in their ancillary benefits for preventing antibiotic use in the past few years. So we proposed that vaccines for diarrhea could not only reduce drug resistance disease, but could also reduce the indications for antibiotic use, so reduce antibiotic use for diarrhea, and consequently, going back to the beginning of the talk, could reduce these bystander exposures to pathogens that are carried asymptomatically. So with funding from the Wellcome Trust, we did a simulation modeling study really based on the MALI-D cohort data that I have already described, where we made some assumptions about when vaccines would be given and their efficacy, and estimated the reductions in several antibiotic use outcomes that could be achieved with vaccines. So this is for a Shigella vaccine, and for a variety of different antibiotic use outcomes, the percent reduction that would be expected with a vaccine given at different dosing scenarios. Here, I'm focusing on fluoroquinolones and macrolides, which are the sort of drugs of choice for Shigella and are most at risk for resistance. The sort of assumed vaccine efficacy is really a number that is totally assumed. We don't have a vaccine yet, unfortunately, for Shigella, but these are pegged towards the goals that have been outlined in the preferred product characteristics document from the WHO. So they're pretty modest. So 60% efficacy against severe disease, 40% against non-severe disease. That would result in about a 35% reduction in fluoroquinolone and macrolide uses for Shigella specifically. So for Shigella severe diarrhea, any Shigella diarrhea, and then these bystander exposures that are caused by Shigella. The nice thing about the data that we were using is we have information on all antibiotic courses, not just for Shigella, and so we can estimate impact on sort of the total burden of antibiotic use. And as you might expect, those effects are quite a bit smaller. So we'd only prevent like 5% of antibiotic uses for severe diarrhea overall, 8% of antibiotics for diarrhea overall, only 3% of total antibiotic courses, and similarly about 3% of total bystander exposures. So yes, a vaccine could prevent antibiotic use, but it's relatively limited impact given, as we've discussed, the many different causes of antibiotic use in these populations. We also, I think my last data slide, we also compared a variety of different enteric vaccines, including combination vaccines. So yellow here is a combination viral vaccine against adenovirus, norovirus, and rotavirus. Green is a Shigella ETEC vaccine. And so, not surprisingly, you get bigger benefits when you have a combination vaccine, something like a 6 to 9% reduction in antibiotic use for diarrhea due to any cause. But again, if we look at antibiotic courses overall or these bystander exposures, you still only see 2% maximum reduction in total antibiotic uses. So still quite limited impact, again, just given the very many causes of antibiotic use in these populations. The last piece of this project is we're sort of projecting globally what reductions could be achieved using globally representative data sets like the DHS surveys, as well as more globally representative etiology information from the Global Pediatric Diarrhea Surveillance System, and so can sort of show differences globally in the expected reductions in antibiotic use from a Shigella vaccine. I'll note even the darkest pink color here is a 4% reduction. So again, modest impact, but not when we think about absolute numbers of courses that are prevented. So in summary, children in these low-resource settings are an important place to use vaccines to prevent antibiotic use because they have really high burden of diarrhea, really high burden of antibiotic use, really high burden of these bystander exposures. But vaccines would prevent a relatively small proportion of antibiotic use overall, and we need combination vaccines or some other combined interventions to make a more measurable impact on the total burden. Okay, my last conclusion to wrap everything up. We're in this really tough balancing act where antibiotics for children with diarrhea in low-resource settings are too much and also not enough. So this is a population with very high mortality, and so I think we have an ethical obligation not to withhold treatment when it can benefit children. But at the same time, we need to be effectively targeting treatment to those who benefit, so we prevent overuse and antibiotic resistance. Of the 3 projects I showed you, the hemoglobin assay could be used at the point of care and is reasonably useful, I think. We may be able to do better targeting just using host characteristics and predictive algorithms, and any way that we can prevent illness is a great way to prevent antibiotic use because you prevent the indication for treatment. So with that, I will thank a ton of collaborators, my longstanding group of collaborators at the University of Virginia, as well as at Emory, and then the many huge networks and groups of participants that contributed to this from around the world. So really appreciate all their inputs. And I'm happy to answer questions.
Thanks so much for an amazing talk. Yeah, let's open to questions, and I can distribute these. I'm not going to throw them because I'm a little worried.
Thanks. That was really interesting. Is this on? Oh, cool. So I was really interested in what you were saying about asymptomatic carriage of things we call pathogens. I've got a number of questions around that, but I'll stick to one. If you can get asymptomatic carriage of things we call pathogens, presumably sometimes they may be being carried when something else is causing the diarrhea. And how do we then account for that?
Great question. A huge amount of work focused on accurately attributing the cause of diarrhea. So you're exactly right. When we look in diarrheal stools, we often find more than one pathogen present. So there have been several large studies, including the MALI-D study, as well as other large case control studies that leverage detections, the comparison of detections between diarrhea cases and non-diarrheal controls to try to attribute which is the cause of diarrhea. So what's most commonly done is you model the association between pathogens and diarrhea. You get an odds ratio, for example, and you can estimate an attributable fraction, 1 minus 1 over the odds ratio. So you can get, for a specific episode, an attributable fraction. So we say attributable fraction for Shigella is 0.7. So, heuristically, 70% chance or 70% assumption that that episode is caused by Shigella. That sort of analysis has been used to develop these quantity cutoffs. So I kept mentioning detection of Shigella at a quantity that's high enough that we think is the cause of diarrhea. And so that's based on...
And of course, you've got some of your work has shown that it also causes watery diarrhea. So that should be taken into account as well.
Yes, so that's sort of irrespective of whether it's watery or bloody. You see a very nice approximately linear relationship. The more quantity of pathogen, the more likely it's in a diarrheal stool, the more likely it's causing diarrhea. And so you can either if you have these associations, you can say for a specific episode this attributable fraction that can be based on age and other factors. Or if you're trying to make inferences in a study where you just have diarrhea, we generally use a quantity cutoff that corresponds with the strong association with diarrhea. So like the quantity at which the odds ratio for diarrhea is 2 or something. And that's how we attribute etiology. This is really the life work of James Potts Mills, and we've done a ton of studies to try to interrogate this further, including, for example, my biomarkers. So it's a sort of an independent test of etiology. So you can compare Shigella that we're calling attributable based on quantity compared to Shigella detected but at a lower quantity versus no Shigella. And you see that the biomarkers are much lower if they're detected but not attributable. So the detected but not attributable looks more like Shigella negative than what we're attributing. We also have studies of serology that shows you make a really nice immune response to Shigella if it's at that higher quantity, but not if it's at that lower non-attributable quantity. So I think we feel fairly confident that we're doing a decently good job at attributing in these settings. But you're right, it's challenging and subject of a lot of work. Yeah.
That was horrifying.
Bo did. This was the tryouts. So you spoke about the ABCD trial, and you seem relatively unconvinced, not to say completely opposed to the finding. So I was wondering if you can maybe provide some insights into what you think went wrong. Like, was it the study design, the data analysis, or the interpretation of results?
Yeah, great question. So I'm a relatively latecomer to ABCD, but I'm channeling Patty Pavlinak at the University of Washington, who was much more involved in this study. I think partially it comes down to poorly powering the trial. So, it was stopped for futility because mortality was much lower than expected. So what are the reasons for that? One could be that it's a randomized trial. These children are, very well managed, and just children don't die when they're very well managed. So not only, even if you were in the placebo arm, you were getting presumably a superior standard of care, and so mortality was lower. The other, I think the key nuance there was that the inclusion criteria for ABCD, you had to be at higher risk, so you had to have some amount of malnutrition or dehydration, but they specifically excluded children with severe acute malnutrition. So there's already an antibiotic indication for severe acute malnutrition, and through apparently many heated discussions, they decided to exclude that group. That group is at highest risk for mortality, so that may be the reason why mortality was lower than expected. I would say that my group, we would argue that they probably shouldn't have excluded that group. So children with severe acute malnutrition often get ampicillin gentamicin, which probably isn't the most effective against something like Shigella. I think there's an argument for treating, you could additionally treat kids with SAM with azithromycin and potentially also see a benefit. So we're attempting to get European funding, not American funding, but European funding, to do a sort of a ABCD 2.0, which would be, can we better, so based on some of these analyses, can we better target the children that benefit based on not diagnostics but host characteristics? And the plan would be to include children with severe acute malnutrition because we think azithromycin could be sort of additive on top of the Amgen that they're getting.
We have one last question from Zoom. When measuring predictive power for biomarkers, is there any consideration for the presence of more than one species that passes the threshold for being considered the etiologic cause of diarrhea?
Okay, I'm glad someone asked that because someone has to ask about co-infections at least once in every talk. Yes. Currently, we're sort of ignoring it. So you can be attributed to multiple things, and we consider them independently. We account for other pathogens in the predictive algorithms, but we're not sort of directly modeling synergy between pathogens. But it is true that even in Shigella cases where there's a high quantity of pathogen detected, about a third of the time you detect another pathogen at high quantity. So you have these co-etiologies detected. And so that could be one reason why the performance isn't stellar, for example. But I think in general there's just a lot of heterogeneity and inflammation, even among Shigella cases. And so my guess is that's not the main reason for the sort of not stellar performance, but it is a